G'day team, and welcome back to Overheard in the Emergency Room, the show where we discuss all the things I wish patients knew before they needed to come see me with an emergency. If you're enjoying our content, take a moment to like and subscribe so that you don't miss any of our content. Let's start with today's case. I had a 49-year-old woman presenting to the emergency department with progressive shortness of breath. Her BMI is 48. For 2 weeks, she's been increasingly breathless. Her legs are swollen, her oxygen saturation is 92%. Her heart rate is 110 beats a minute. Her primary doctor was worried about heart failure and had referred her for an outpatient echocardiogram. So I did a bedside ultrasound. It showed McConnell's sign and reduced TAPSE, both evidence of right heart strain. I was really worried about pulmonary embolism, basically a clot that goes from the legs up to the lungs, particularly given her high heart rate, her respiratory rate, and her mild hypoxia. Also, her PCP was concerned about heart failure, but the context of the patient's history and exam wasn't really consistent with this. So I figured let's have a peek at the heart now and see if that was likely to be the case. We couldn't immediately access our standard scanner due to equipment weight and waist circumference limits. Given my initial concern for pulmonary embolism, we started anticoagulation empirically while we arranged transfer to a bariatric capable scanner. Eventually, the imaging study confirmed the patient had bilateral segmental pulmonary emboli, which is pretty significant. Now, I'm not an obesity medicine specialist, but I see the complications of obesity every week in the emergency department. And today, we are going to walk through the major guideline recommendations for obesity care, because this is a chronic disease that deserves structured, evidence-based treatment. Let's get into it. All right, let's start by framing this episode. Obesity is recognized by major organizations, including the American Heart Association, the Obesity Society, and the American Association for Clinical Endocrinologists, as a chronic, relapsing, multifactorial disease. Obesity is not a character flaw, not laziness, not lack of discipline. Measurements like BMI are screening tools, not a moral scorecard. Today, we're going to talk about what causes obesity, how much of a problem it is, and go through some ways to manage it that are consistent with evidence. Where do we get that evidence from? The guidelines. These are documents that guide clinicians in their work with patients every day. They're developed by experts who use the power of epidemiology, mechanistic, and clinical trials to determine the best ways to help manage these diseases. Broadly speaking, the guidelines recommend a comprehensive assessment of comorbidities, screening for sleep apnea, mental health review, medication assessment, weight history, eating behaviors, and the social determinants of health. Notice what is not part of that evaluation. Shame, or this one thing that you are doing that is stopping you from losing weight, for example. This episode is unfortunately going to be about the complexity of this condition and why this condition requires a team approach. Let's zoom out for a moment, because before we talk about treatments, before we talk about stigma, before we talk about medications, we need to understand something fundamental. Body weight is not simply about willpower. It is regulated. Your body is constantly trying to maintain energy balance, what we call energy homeostasis. This is coordinated primarily by the nervous and endocrine systems. At the center of it all is the hypothalamus. Think of it as mission control. It integrates signals about energy stores, nutrition intake, hormonal levels, stress, sleep, and inflammation. What is its job? It's to defend survival, not aesthetics, not a beach body, survival. Several hormones act as messengers in this system, and let's go through them one by one. First, leptin, the satiety signal. Leptin is released from fat cells. It tells your brain we have stored enough energy. Higher fat mass, higher leptin levels. But here's the twist. In obesity, leptin levels are often high and your brain becomes leptin resistant. So the signal is there, the brain just doesn't hear it properly. Second is ghrelin, the hunger signal. Ghrelin is produced primarily in the stomach. It rises before meals. It stimulates appetite. After weight loss, ghrelin levels increase, driving hunger higher. This is not psychological weakness, that is endocrine adaptation. Next is insulin, the energy storage hormone. Insulin regulates glucose metabolism and promotes fat storage and insulin resistance. Higher insulin levels are required, fat storage is promoted, energy utilization becomes less efficient. Insulin resistance both contributes and results from excess adiposity. It's a feedback loop. Cortisol, the stress hormone, we've talked about this before. Chronic stress elevates cortisol, and cortisol increases appetite, promotes central fat deposition, and disrupts normal metabolic regulation. Add chronic sleep deprivation to that mix and you amplify the dysregulation. So those are the main hormones at play. Now we have to talk about what happens when your body starts to fight back. And here's the part that most people don't understand. When someone loses weight, resting energy expenditure decreases. Hunger hormones increase, satiety hormones decrease. This phenomenon is called adaptive thermogenesis. Your body becomes more metabolically efficient, it burns fewer calories at rest, it increases the drive to eat. From an evolutionary standpoint, that's brilliant. From a modern standpoint, it makes sustained weight loss very difficult. Your brain is defending a set point. As with many other conditions we've talked about, genetics play a very important role. Twin studies show BMI heritability estimates approximately 40 to 70% of obesity incidence. That doesn't mean that it's destiny, but it does mean you have a significant predisposition and makes it hard for folks. Certain rare monogenic forms of obesity, such as mutations affecting melanocortin receptors, directly impair appetite regulation. Even in common obesity, genetic variants influence appetite signaling, energy expenditure, fat distribution, and response to diet. So different bodies respond differently to the same environment. Weight regulation isn't just homeostatic, it's hedonic. By this, I'm talking about the brain's reward circuitry, the dopamine pathways, motivation circuits, and food cue responsiveness. Highly palatable foods amplify reward signaling. In an environment saturated with ultra-processed, energy-dense foods, the system is constantly stimulated. This isn't just about hunger, it's about reinforcement. Obesity is associated with chronic low-grade inflammation. As we already discussed in our metabolic disease episode, adipose tissue releases pro-inflammatory cytokines like TNF-alpha and IL-6. This inflammation worsens insulin resistance, contributes to metabolic dysfunction, and may influence cognitive and neurobiological processes. This is why obesity is not simply excess weight. It's a systemic inflammatory state. Now layer on sedentary lifestyle, high-calorie food abundance, socioeconomic barriers to healthy food access, chronic stress, and poor sleep. This is not a fair fight. You are taking a brain wired for survival and placing it in an environment engineered for overconsumption. Obesity is neuroendocrine, genetic, environmental, behavioral, and inflammatory, all rolled into one horrible mess. It is not a moral defect. It is a dysregulated biological system responding to a modern environment. And when you understand that, treatment stops being about blame and starts being about physiology. Let me give you an analogy. Think of body weight like the temperature in your house. You don't manually adjust your furnace every 5 minutes. You set a thermostat. If the temperature drops below that set point, the heat kicks on. If it rises above that set point, the cooling system activates. Your brain does something similar with body weight. It has a defended range, not a single number, but a zone. When the weight drops below the defended range, hunger increases, satiety signals weaken, energy expenditure falls. Food becomes more rewarding. That's the heat turning on. When the weight rises above that range, satiety signals strengthen, energy expenditure increases slightly. That's the cooling system. Now here's the problem. In obesity, the thermostat can shift upwards. Genetics, environment, chronic overnutrition, inflammation, sleep deprivation. Over time, the brain recalibrates. Now what used to be high weight feels normal to the hypothalamus. And when someone tries to diet below that new set point, the brain responds like it's freezing. It doesn't see, I want to lose 20 pounds. It sees, we are starving. So it turns up hunger, turns down metabolism, increases reward drive. That's not weakness. That is the thermostat defending what it believes is survival. Let's zoom out. This is not a niche issue, it is widespread. Working in the US, I often hear about my fellow Aussies and how they're bronzed up fitness freaks. I gave a TEDx talk in Boston that explained Australia's life expectancy in 2024 and how it was 7 years longer than in America. I thought that it would be pretty straightforward. Obesity is America's disease, right? But is that the truth? Well, in Australia, 65.8% of adults are overweight or obese, and 31.7% meet criteria for obesity. In the United States, adult obesity prevalence has risen from 30.5% in '99 to approximately 42% in recent data. So not that different. That means roughly 2 in 5 American adults live with obesity. In a nod to the future of healthcare and some of our upcoming challenges, the prevalence has increased from 13.9% to over 20% in the last 2 decades in adolescents and children. Severe obesity is rising fastest. This is not static, it is accelerating. In Australia, severe obesity, BMI greater than 40, has more than doubled over the last 15 years, and waist circumference data shows nearly 45% of adults have measurements consistent with substantially increased cardiometabolic risk. This is not cosmetic, this is metabolic risk accumulating at a population level. Now, bring it back to the ED. In emergency medicine, obesity changes so many things: airway management, medication dosing, VTE risk, imaging logistics, surgical risk. When I can't get a patient into the CT scanner because of weight and size limits, that is not a personal failing, that is a systems reality and a systems failing. Now let's talk about money, because chronic disease doesn't just affect physiology, it reshapes healthcare systems. By now, you all know that I love contrasting and comparing the healthcare systems of my 2 countries, Australia and the US. So let's start in the Southern Hemisphere. In Australia, the economic cost of overweight and obesity was estimated to $39 billion in 2019, nearly 2% of GDP. And projections suggest it could exceed $87 billion annually within the next decade. In the United States, direct medical costs are estimated at between $147 and $210 billion per year. That's about 10% of all medical expenditures. And that's just direct healthcare costs. Indirect costs include things like absenteeism, reduced workforce participation, disability, caregiver burden, and reduced productivity. In the US, absenteeism alone has been estimated to cost $8.6 billion annually. Globally, projections suggest obesity could cost the world economy over $4 trillion annually by 2035. That's comparable to the financial toll of COVID in 2020. Let's just take a moment on that. This is not about making sure everyone has a beach-ready body. This is about ICU bed capacity, dialysis, orthopedic replacements, insulin and diabetes incidence, and stroke rehab. This is also about participation in the workforce and long-term happiness and healthfulness of all of our communities. And in the ED where I work, it's about preventing the complications of this disease before they ever arise. When 40% of adults have a chronic disease that increases cardiovascular risk, cancer risk, and thromboembolic risk, and costs hundreds of billions of dollars annually, the correct response is not shame. The correct response is structured treatment. All right, let's talk about guidelines. Now, there's a lot of noise out there about healthcare and the interventions available to patients, particularly when there is money to be made. I've said this before. I'm an emergency physician. I treat a lot of serious medical issues, heart attacks, strokes, and diabetic emergencies, to name a few. But I'm not a cardiologist, a neurologist, or an endocrinologist. But I know where to find information that has been vetted by experts to ensure treatment is evidence-based. Treatment guidelines are an excellent start for finding this kind of information. Let's take a short history lesson. In 2013, the American Medical Association designated obesity as a chronic disease. In 2014, the American College of Cardiology, the American Heart Association, and the Obesity Society published clinical practice guidelines for the management of overweight and obesity in adults. In 2016, the American Association of Clinical Endocrinologists and the American College of Endocrinology published evidence-based clinical practice guidelines that built upon the AMA's designation. The AACE's novel diagnostic paradigm incorporated both body mass index and weight-related complications and suggested that weight-related complications, rather than universal weight loss target, determine treatment modality selection. These two comprehensive documents remain the most accepted guidelines for the treatment of obesity. Since these guidelines were published, a lot has changed in the pharmacological landscape for treating obesity. So let's take some time going through these two guideline documents so we can better understand what it takes to evaluate and then commence treatment for obesity. So first up, screening and diagnosis. Both guidelines recommend that all adults be screened annually using BMI measurements to initiate an evaluation for overweight and obesity. The guidelines recommend that a BMI of greater than 25 in any patient prompts further evaluation, and a BMI of at least 23 may warrant such evaluation in patients of South, Southeast, and East Asian genetic heritage. To diagnose obesity, both BMI measurements and clinical assessment of weight-related complications are recommended. In addition to BMI, waist circumference should be considered in patients with a BMI of 25 to 35. Waist circumference of at least 102 centimeters in men and 88 centimeters in women indicates abdominal obesity, which is associated with increased risk for adiposity-related disease. The guidelines recommend different cutoffs depending on regional and hereditary factors in certain populations. Next up, the clinical assessment of weight-related complications. Patients with overweight or obesity should be screened for diabetes, dyslipidemia, hypertension, metabolic syndrome, cardiovascular disease, non-alcoholic fatty liver disease, osteoarthritis, and mental illness, such as anxiety and depression. They should also be evaluated for obstructive sleep apnea, asthma, and reactive airway disease, as well as gastroesophageal reflux disease. When you think about that long list of weight-related complications, I hope that you're beginning to understand how complex this disease is and how challenging it is to manage. Something we'll talk about later in this episode is the wellness grift. And my biggest gripe with these folks online is how they boil obesity down to just one problem and that they have a simple solution to sell you. This couldn't be farther from the truth. Obesity is a complex, multifactorial, chronic disease that requires multidisciplinary approaches to manage and prevent its complications. Next up, establishing prevention and treatment targets. Clinicians should use history and physical examination to better understand the patient's risk of overweight and obesity and to determine how comprehensive lifestyle interventions and adjunctive therapies have already been used. Patients with normal BMI and those at risk for overweight and obesity should be counseled to avoid weight gain and be educated in the Tier 1 lifestyle interventions, such as diet and physical activity. The guidelines don't specifically address the Overheard in the emergency room Tier 1 interventions, sleep and medication. But if you check back in on our sleep episode, we discussed many studies showing a correlation between poor sleep and the development of obesity and diabetes. So check in on that episode to get a better understanding of how to optimize your sleep for better long-term health. Now, for folks who already have stage 1 or stage 2 obesity, both guidelines recommend at least 5 to 10% body weight loss because early body weight loss helps predict sustained weight reduction. The AACE and ACE recommendations target 2.5% weight loss within the first month for all patients and achieving a realistic, meaningful goal of 5 to 10% weight loss in 6 months. This leaves us with the question, how do we actually achieve this? Treatment is where the online debate goes wrong. Many commentators suggest that physicians simply write a prescription and send patients on their way. This couldn't be farther from the truth. Both guidelines recommend aerobic exercise and resistance training, along with a reduced calorie diet, promotion of active leisure time pursuits, and reduced sedentary time. These activities can be conducted by the individual and in group settings. Some strategies to help achieve this include goal setting, self-monitoring of food intake, dietary education, gathering with peers, social support structures, group exercise classes as well. These interventions should use multidisciplinary approaches and leverage the expertise of psychologists, psychiatrists, and dietitians, and can be done in person or remotely. Remember, our goal is to lose 10% of body weight in the first 6 months. The best way to achieve this is to conduct an in-person, high-intensity program that's greater than 14 sessions in the first 6 months. If this can't be achieved, the next best approach is online, ensuring access to that multidisciplinary team. So let's bring this home to something familiar. If you've listened to this podcast before, you know we use the 2-tier framework. Tier 1 is the foundational lifestyle interventions, and Tier 2 are the adjunctive medical and procedural interventions. The guidelines are clear. Tier 1 is not optional. It's not punishment. It's not a prerequisite prior to medication. It is the foundation of long-term metabolic health. So what does Tier 1 include? Here's where I'm going to blend my ideas with some concepts we've already discussed on this show. First off, diet. Both major guidelines recommend reduced calorie dietary patterns. But here's the nuance. They do not mandate a specific named diet like Mediterranean, DASH, vegan, low carb, or low fat. What matters most is adherence and caloric deficit, not tribal diet identity. In previous episodes, we discussed my elevator pitch for diet and the 80-20 plate. That is a protein anchor with a bias for plant sources of protein like beans, lentils, and tofu, fiber-rich vegetables and fruit, whole food carbohydrates, and healthy fats, where you substitute saturated for poly and unsaturated fats, all the while minimizing ultra-processed foods. And a quick note on protein, because there's a lot of debate about protein out there. How much do we need? What type of protein should we be eating? And so forth. I think this conversation goes off the rails super quick, and it's incredibly unhelpful for people who are just trying to do their best. The answer is simple. Protein is important. It helps build muscle and helps with satiety. But if you aren't lifting weights, you are not giving your body the stimulus it needs to build or maintain muscle. So step 1, lift weights. Step 2, eat protein. But choose plant sources. They carry fiber and carry a lower risk of diabetes and cancer. Also, because of the fiber, they have a very important dietary component that increases satiety. Protein deserves an entire episode of its own, and something we'll certainly come back to. The goal isn't perfection. The goal is sustainability. So choose a dietary approach that is consistent with these 5 parameters, honors your tastes, your culture, and your time constraints. Just make sure that you're in a calorie deficit. Tracking with apps like Chronometer can be super helpful. Exercise. We've talked about this extensively in a previous episode. I used to be a strength and conditioning coach, so I love to talk about exercise, and the parameters for folks trying to lose weight are pretty straightforward. Both guidelines recommend greater than 150 minutes per week of moderate intensity aerobic activity. This can be zone 2 cardio, so slow, steady pace activity with a heart rate in zone 2, around 110 to 130 beats for most people, or 3 to 4 out of 10 in intensity, or just being able to hold a simple conversation with being too out of breath. You need to resistance train 2 to 3 times per week. You might need some help with this and should engage with a trainer. But the short and skinny on this is if you choose 3 to 5 exercises, do 2 to 4 sets of 8 to 15 reps per exercise. That will basically get you where you need to be. Visit my website, drcois.com, for free training guides. When you're choosing a weight to lift, ensure that it challenges you so that you could probably only do 2 to 3 more reps per set. Why resistance training? Because lean mass is at risk when you're trying to lose weight, and preserving muscle mass preserves metabolic rate. Remember, muscle is not just cosmetic, it's metabolic currency. Sleep. Now, the guidelines don't specifically highlight sleep that prominently, but the evidence is strong. Short sleep duration has effects on hormones, including appetite regulation and weight control. Short sleep has been linked with increases in ghrelin, decreases in leptin, it impairs insulin sensitivity, increases caloric intake as well. We've covered this in episode 4 and went through the mechanisms of sleep and what the large cohorts say about sleep and chronic disease. And we also talked about how you can start to optimize your sleep today. Chronic sleep restriction can increase obesity risk by 30 to 50% in cohort data. You cannot optimize metabolic health if you're sleeping 5 hours a night. Next up, stress and meditation. Stress and meditation is a muscle that needs to be trained. Now, I've created a few simple resources to help train these muscles. The first is a simple box breathing exercise. We know that chronic stress elevates cortisol. Elevated cortisol drives visceral fat deposition. Mindfulness, breath work, they're not fringe. They're autonomic regulation tools that you should use liberally, but you need to practice them. We also covered this in a previous episode. And what stands out to me is that very small practices can have incredibly meaningful effects. Obesity is partly a disease of chronic stress biology. And our final element of Tier 1, the medical team. So who are you going to have in your corner? The guidelines are explicit about this. High intensity, multidisciplinary programs, that is greater than 14 sessions in 6 months, produce the best outcomes. That means you need dietitians, behavioral therapists, physicians, and exercise professionals, all part of the mix. Obesity management is not a solo sport. It is team-based chronic disease care. Now here's the honest part. Even when Tier 1 is done well, for many patients with stage 2 obesity and metabolic complications, lifestyle interventions alone are insufficient for durable weight loss. That's not failure, that's physiology. And that brings us to Tier 2. Let's get straight to the data on pharmacotherapy. No vibes, no TikTok takes, just randomized control trials. We mentioned earlier that since the guidelines were published, there have been numerous FDA-approved medications for weight loss, which are really changing the landscape for obesity management. So step 1, semaglutide, published in New England Journal of Medicine in 2021. The first and really groundbreaking trial of new age pharmacotherapy for obesity management was the Step 1 trial, a double-blinded trial of over 1,900 adults with BMI of 30 or greater, or BMI of over 27 with one weight-related coexisting condition, and without diabetes. The intervention was semaglutide 2.4 milligrams weekly plus lifestyle interventions. The comparator was placebo plus lifestyle. And the outcome at 68 weeks was a mean weight loss of 14.9% with semaglutide versus 2.4% with placebo. That's a treatment difference of 12.4 percentage points. That's huge. Over 1/3 of participants lost greater than 20% of body weight. Now remember, our goal of weight loss should be around 10% by 6 months. That's not cosmetic weight loss, that is disease-modifying weight loss. So the next trial is Step 4. What happens when you stop? This is the trial that critics love to cite. Step 4 examined continuation versus discontinuation after a 20-week run-in period. When semaglutide was stopped, weight regain occurred, with difference of around 14% between groups. The placebo group regained 7% after initial 10% weight loss, and those in the treatment group continued to lose weight of around 8%. Those who continued the medication maintained and deepened weight loss. The Endocrine Society guideline predicted this years earlier when they noted in their pharmacotherapy section, weight loss medications lower weight to a new steady state, and weight typically rises when they are stopped. So this was already flagged in 2016. Instead of seeing this as a negative, we can simply reframe our thinking around obesity. It is chronic, and treatment may need to be chronic. This is identical to other conditions like hypertension, as well as using medications like insulin and SSRIs for diabetes and depression. That shouldn't be scandalous. This is the outcome of the interplay of human biology and our obesogenic environment. Do we want patients to be on medications indefinitely? No, but sometimes the risk-benefit equation is such that long-term medication is necessary. And that's backed up by the data. Next up, SURMOUNT-1. So the SURMOUNT-1 trial was published in the New England Journal of Medicine in 2022. It looked at a dual agonist for GIP and GLP-1 receptors, tirzepatide. The brand names are Mounjaro and Zepbound, in patients who had overweight and obesity. So the population was adults with overweight and obesity plus complications, but without diabetes. Tirzepatide 5, 10, 15 milligrams weekly was the intervention, with a control group that received a placebo injection. The outcomes after 72 weeks were separated by dose and are as follows. 5 milligram group lost 15% body weight. 10 milligram group lost 19.5% body weight. And the 15 milligram group lost 20.9% body weight, with placebo only losing 3.1%. Let's sink that in for a moment. Up to 21% mean body weight reduction, and in 50% of patients on 10 to 15 milligrams, they lost greater than 20% body weight. In addition to that, cardiometabolic markers improved across the board. That is bariatric level weight loss without surgery. But what about adverse events? It's always important to consider these. These were mostly gastrointestinal and mostly happened during the dose escalation. This is one of the most common times that I will see patients in the emergency department. They come to see me with profuse nausea and vomiting. Oftentimes they use a compounded version of GLP-1 agonists through a subscription service. I often see that their dosing has been escalated based on some algorithm. Oftentimes they are already losing weight appropriately. In my mind, this highlights the need for a comprehensive, multidisciplinary team approach to the care of patients with obesity. The discontinuation rates in this study were 4 to 7% for the treatment group versus 2.6% for placebo. So although there are side effects, the majority are manageable and don't make patients stop taking the medications in significant numbers. Medications have been used for obesity management for a long time, so it's not a new concept. We've been trying to find good options for a long time now. So here's some historical context. An RCT published in The Lancet in 1998 compared the treatment group receiving Orlistat, 120 milligrams 3 times daily, with placebo. Orlistat is a reversible inhibitor of gastrointestinal lipases, so gastric and pancreatic, that act in the lumen of the stomach and small intestine. They help to reduce dietary fat absorption by approximately 30%. Researchers found about 10% weight loss in the treatment group versus 6% in the placebo group at 1 year. And there was less weight regain in the treatment group at 2 years. So modest weight loss, but it was clinically meaningful. But nowhere near GLP-1 GIP magnitude. Pharmacotherapy has evolved, and we should continue to understand how we can leverage the benefits of these medications to help patients suffer less and live their best lives. Now let's talk about surgery, specifically the Swedish obesity subject study. This is one of the longest running obesity outcome trials ever conducted. So the population was a group of 4,000 adults with obesity. The intervention they received was bariatric surgery, which could be gastric bypass, banding, vertical banded gastroplasty. The comparison, because you can't do sham bariatric surgeries on people, they had matched usual care controls. The long-term outcomes showed sustained weight loss of 16 to 23% at 10 to 20 years. They found an overall 29% reduction in mortality, reduced cardiovascular deaths, reduced incident type 2 diabetes. Now, this is over 20 years, not 72 weeks, 20 years. It showed mortality benefit. That's not aesthetics, that's survival. It's truly outstanding. Now, I can understand people being anxious about surgery and having complication of surgery, but the data showed that the perioperative mortality in modern bariatric centers is about 0.1 to 0.3%, which is comparable to cholecystectomy or gallbladder removal, a super common surgery. So the real question is, what is the risk of untreated severe obesity? It's exponentially higher. So let's wrap our treatment discussion up with a 30,000-foot view of how obesity is treated. First, you have tier 1. The goal is for 5 to 10% weight loss and improvements in comorbidities. It's a foundational requirement and includes a calorie-restricted diet, exercise, sleep, meditation, and the deployment of a multidisciplinary team. Tier 2. First step is medication. Using newer medications like GLP-1 agonists and GIP medications can lead to profound 15 to 21% weight loss. This results in further cardiometabolic improvements, and patients may need chronic therapy. Tier 2 surgical interventions. Bariatric surgery can result in 20 to 30% weight loss and has been shown to be incredibly durable and reduces the cardiometabolic morbidity burden and mortality associated with obesity. This is not fringe medicine. This is guideline-endorsed, evidence-based care. Let's talk about the thing we don't talk about enough, weight stigma. Because if we don't address this one, none of the science we just discussed will land. According to a review by Puel and Hewer, obese individuals are highly stigmatized and face prejudice and discrimination across employment, education, and healthcare settings. And here's the part that should stop us in our tracks. The prevalence of weight discrimination in the United States increased by 66% over a decade. That is not improvement, that is escalation. And healthcare is not immune. More than 50% of primary care physicians in one study described obese patients as awkward, unattractive, ugly, or non-compliant. Physicians in experimental vignette studies reported less desire to help heavier patients. They had an expectation of poorer compliance, felt more frustration, and reported less patience with their patients. And here's the clinical consequence. Physicians indicated they would spend less time with heavier patients. If obesity is a chronic biologically complex disease and we spend less time with those patients, how exactly do we expect outcomes to improve? This isn't just feelings. Weight stigma leads to so many problems, including avoidance of medical care, delayed cancer screening, and less preventive care utilization. In one study, women with BMI greater than 55 had 68% delayed seeking of care because of weight, and 83% reported weight as a barrier to receiving appropriate care. They also reported feelings of embarrassment, inappropriate comments, equipment that didn't fit, like our patient at the start, and being blamed for unrelated conditions. If we want fewer myocardial infarctions, if we want fewer strokes, if we want fewer pulmonary embolisms like the patients we open with, then stigma is not just a moral problem. It's a public health problem. The review from Puel also documents that weight stigma is associated with depression, low self-esteem, maladaptive eating behaviors, and avoidance of physical activity. All of the tier 1 interventions we want these patients to be doing. And let's be crystal clear. Shame does not improve metabolic health. It worsens it. You cannot bully biology into submission. If anything, chronic stress and cortisol dysregulation are likely to make visceral adiposity worse. The AAC and AHA guidelines emphasize that obesity is a chronic disease requiring structured management. Stigma frames obesity as a moral failure. Medicine frames it as pathophysiology. These two frameworks cannot coexist. And if we want results, we need to remove shame from the exam room. Now let's pivot, because here's the paradox. On one side, we have stigma and blame in medicine. But on the other side, we have wellness influencers promising simple fixes. And this is where nuance matters. An article titled "Rethinking the Wellness Influencer" makes an important point. Even medically qualified influencers can contribute to confusion if they rely heavily on personal narrative, selective science, or lifestyle branding. Credentials alone do not equal clarity. So here's 5 red flags to look out for when trying to discern quality information from possible misinformation. Myth number 1, overly simple solutions. If someone's telling you to simply cut sugar, just fix your gut, or stop those seed oils, be aware. Remember, obesity is neuroendocrine, genetic, environmental, and behavioral all rolled into one. If the solution fits into a meme, it's probably incomplete. Guidelines emphasize comprehensive, structured, multi-component therapy. Myth number 2, appeal to nature fallacy. If the influencer is saying natural foods heal, ancient diets cure, or your body can self-heal if only you can detox, be aware. Natural does not equal safe. Natural does not equal effective. Botulinum toxin, for example, is natural. The question isn't, is it natural? The question is, are there high quality human outcome data to go with this claim? Myth number 3, mechanisms without outcomes. You'll hear the influencer say, this reduces inflammation, this improves insulin sensitivity. This improves insulin signaling, or this increases mitochondrial efficiency. Mechanistic plausibility is not the same as clinical outcomes. GLP-1 receptor agonists have randomized human trials showing 15 to 21% body weight reduction. Bariatric surgery shows mortality reduction at 20 years. That's outcomes. If the influencer never cites randomized control trials, be cautious. Myth number 4, a supplement-centric business model. If the entire solution funnels you toward a proprietary powder, a detox kit, or a gut cleanse protocol, pause. The guidelines emphasize lifestyle plus pharmacotherapy plus surgery, if appropriate. Supplements are rarely first-line therapy. Myth number 5, anti-establishment framing. Sometimes you'll hear the message, doctors don't want you to know this, or big pharma is hiding the truth, or your GP is ignorant. If you hear that kind of stuff, be skeptical. Are there failures in medicine? Absolutely, and we work very hard to try to correct those. But conspiracy framing increases emotional engagement, not evidence quality. The article I mentioned earlier also notes that credentials do not automatically prevent oversimplification or brand building narratives. Evidence is not determined by a vibe, it's determined by data hierarchy, and that is exactly what we're trying to build with this show here. All right, let's bring this home, because if stigma fails and influencer oversimplification fails, what actually works? Guideline-directed multidisciplinary care. That's what works. The 2013 AHA-ACC TOS guideline emphasizes comprehensive lifestyle intervention with structured, high-intensity support. So that's up to 14 to 16 sessions per year. The AACE guidelines emphasize using a chronic disease model, individualized therapy, nutrition, and physical activity, including behavioral health therapy and pharmacotherapy when indicated. They also recommend bariatric surgery for severe disease. This is not a solo sport. It needs a team. That team should include primary care physicians and obesity medicine specialists, registered dietitians, behavioral health specialists, exercise professionals, and bariatric surgeons. Now, the guidelines specifically support escalation of therapy when lifestyle alone is insufficient. That's not failure, that's a stepwise, evidence-based care. Obesity is not a character flaw, a willpower problem, or a detox deficiency. It's a chronic, relapsing neurohormonal disease with environmental amplification. The path forward is compassion, structure, escalation when appropriate, and an approach that favors evidence over ideology. As we wrap up this episode, I want everyone to remember that obesity is not a character flaw. It's not a moral failing, despite what social media grifters might make you think. It's a chronic disease, one that is born out of our obesogenic environment, driven by our biology, genes, time pressures, and cheap, nutrient-devoid calories that are incredibly tasty. Chronic diseases require structured treatment. My hope is that after getting to the end of this episode, you have a better understanding of what that structure should look like. Beware of anyone who is selling you a one-size-fits-all product that promises you the world. The treatment of obesity is a marathon, not a sprint, and requires input from all members of the team. Today, we spoke in detail about our two-tier blueprint, starting with lifestyle interventions and then pharmacological and surgical interventions for managing obesity. Why am I passionate about this? Well, it's because I see the downstream effects of letting obesity run wild for years. More heart attacks, strokes, cancers, and infections from diabetes complications. This all results in pain for my patients. If you like this episode, please like, subscribe, and drop a comment below so that more people can hear this information. Also, check out my website at drcois.com for free resources to help you navigate your journey to better health. This is why I created this show, so you can be empowered to understand what it takes to have fewer bad days and more good decades. See you next time.